In today's webinar, we are going to discuss about the diseases pertaining to the subject of rheumatology. And our first stop would be approach to arthritis. Arthritis, a very, very common complaint which your patients report. So before beginning this talk, I just want to ask the audience that what do they understand between, what the difference is there between these two words of arthritis and arthralgia. Anyone? Is it the same or is it different? So let me explain. See, arthralgia is only a symptom. Okay, it's only joint pain. But whenever we say or whenever we commit the word arthritis, it should be associated with the signs of inflammation. The 4 cardinal signs of inflammation of joint swelling, pain, redness, as well as loss of function should also be there. So these things you need to keep in your mind before labeling the patient with arthritis, that whether it is really arthritis or not. So the symptoms with which a patient of arthritis would be coming to you, definitely there would be pain, there would be stiffness in his joints. Depending upon the stiffness, we can actually classify whether it's inflammatory or non-inflammatory. I would be explaining it to you in further slides. Definitely there would be swelling since it's an arthritis. A prolonged disease will have deformities, weakness of the affected limb or limbs, instability in movement, and loss of function. So evaluation of a patient of arthritis should be according to these 4 points. If you are addressing or if you are able to get some answers for these points, definitely you are on right path in management, in diagnosis as well as management. So the first and foremost point which we need to remember or we need to evaluate is whether it's articular or a non-articular or a periarticular joint pain. Because a patient won't be telling to you that this is actually the articular or not. So you have to communicate accordingly and examine the patient accordingly so that you should be able to decipher the cause of joint pain. So whether it is articular or non-articular, is it inflammatory or non-inflammatory in nature, very important because all the treatment depends upon only these 2 points. Is it acute or chronic in duration? About duration, I will explain it to you in my further slides, whether it is local, that is a monoarticular involvement or a polyarticular involvement. So our first explanation, whether it is articular or periarticular. So what do you exactly mean by periarticular structures? Anyone amongst you? You must have heard these, I would say, words before as well, articular and periarticular. So whenever we say the word articular, it means pertaining to the joint itself. It should be involving the articular joint, that is the articular bony part. It should be involving the articular cartilages. It should be having the synovial lining and the blood vessels which are surrounding it. So this is only the part of articular. Whenever we say the word periarticular, it means everything surrounding the joint. It would be a tendon, it can be a ligament, it can be bursa, it can be muscle as well. Okay, so these points. So whenever there would be articular involvement, the movements would be painful in all directions. Okay, because whenever there is articular involvement, with whichever movement you perform, the movement is actually going to be inside. It won't be outside. Okay, so inflammation of the structures which are present inside the joint would definitely produce pain on any sort of movement. And in periarticular structure, the part of the periarticular architecture which is involved would be producing pain on active movement. Okay, so these are the fine-tuning words and the fine-tuning definitions which would actually help you in differentiating between articular and periarticular. Don't take photographs, I will mail you. Then second important thing is pain in motion with movement. So whenever there would be articular involvement, since what I explained that the movements are actually happening in the structure which are present inside the joint, so whatever movement you do, either active or passive, it will produce pain. But definitely pain would be more with active movements than with passive movements. In this periarticular structure, the part of the periarticular architecture which is with that particular activity will undergo pain or will produce pain. Okay. So restriction of movements, it would be limited in active as well as in passive in patients with articular involvement, while it won't be there though that peculiar way in periarticular one. Restriction of movements, restriction of active movements, there is no effect because it is coming from inside. So definitely no much relief would be there, but yes, subjectively some relief would be there if at all there is rest is provided. And on palpation, the joint line palpation as well as over here, like what I explained about to you about arthritis. So it would be surrounding that joint. The inflammation and the signs of inflammation won't be going away from the joint line. Okay. So this is what is the major difference between articular and periarticular. Our most important one, the differentiating feature, whether it is inflammatory or non-inflammatory, because the whole treatment depends upon this. Inflammatory one, you must have been very familiar with this word early morning stiffness. Whenever, if you are reading something about arthritis or reading especially about rheumatoid arthritis, you must have been aware about this word of early morning stiffness. So it is not just about early morning stiffness, but stiffness after prolonged rest. Since our body is at rest during entire night time whenever we sleep, therefore we are having this symptom of early morning stiffness in rheumatoid arthritis. That doesn't mean that you won't be experiencing stiffness in the afternoon hours. Whenever there would be prolonged rest to the joint, there would be pain. Okay, there would be stiffness and as well as pain. Increased warmth because it's inflammatory one, therefore there would be much more erythema as well. Stress pain is present in inflammatory while it is absent in non-inflammatory. Joint effusion because it is actually a pathology which is starting from inside the joint capsule, so there would be effusion. It may or may not be present in patients with inflammatory, especially if you are asking about osteoarthritis. The osteoarthritis also the knee joint appears to be swollen. Okay, but the swelling is actually not because of peculiar effusion. It would be because of the hypertrophy of the synovium and the structures which are present inside the joint. Crepitus, important one. In fact, most of you must have heard this peculiar complaint of your patient that whenever they are, हमारा पेशेंट जब भी चलता है तो कड़कने की आवाज आती है, पापड़ क्रश होने की आवाज आती है जॉइंट्स में से. So this is nothing but the joint crepitus what we are actually talking about. Okay, so the intra-articular structures which have actually undergone hypertrophy as well as sclerosis because of the persistent, you call it as a disease activity or so, whenever there is a movement, whenever there would be apposition of these structures, it would be producing that peculiar sound which is called as crepitus. While in patients with inflammatory arthritis, since it is the effusion, the joint fluid which is present inside, this crepitus won't be there. Okay. So the amount of apposition which is required is not happening in the patients with inflammatory arthritis. So crepitus is a very important differentiating feature between inflammatory and non-inflammatory one. There would be malalignment. It can be malalignment, can be seen inflammatory as well. So it's not a very a clear differentiating point, and as well as deformities. A long-standing one, definitely it will produce deformity. So the characteristic of pain we need to keep in our mind, that whether it is periarticular pain, which I have already explained from which all periarticular structure the pain can arise. Neurogenic pain, especially if you are dealing with low back pain, sciatica, radicular pain, that whenever there would be compression of nerve or irritation of nerve because of the surrounding structure, it will be giving rise to neurogenic pain, as well as referred pain. Though we usually don't come across this referred pain in arthritis, but we just need to keep in our mind that this can also be one of the features. Duration, in rheumatology, we need to simplify most of the things, and what the studies have actually done. There is no clear-cut LOC between these 6 weeks, but for our convenience, we have taken it 6 weeks. For RCTs as well, it has been documented to be 6 weeks. Okay, so acute and chronic, there should be some entity of subacute as well, but it has not been clear-cut defined. So whenever there would be the duration of arthritis less than 6 weeks, we call it as acute onset, and whenever it is more, it would be chronic arthritis. Just 6 weeks, the number you keep in your mind. The extent of joint involvement, monoarticular, monoarticular means one joint involvement. Usually it's a large joint of your body. Oligoarticular or polyarticular. Polyarticular is the word which we usually use, especially if you are dealing with pediatric inflammatory arthritis of JIA or not. So oligoarticular means 2 to 3. Polyarticular means 2 to 4 actually. Okay, so 2 to 4. Especially in pediatric age group. In the polyarticular group, in adults it would be 4 and more. In pediatric it would be 5 and more. Clinical features and pattern of presentation. So age, dysplasias, especially congenital dysplasia of hip, DDH, you must be aware of this word. Commoner in pediatric age group, JIA. Earlier it was called as JRA. Okay, juvenile rheumatoid arthritis. Now the nomenclature has changed to juvenile inflammatory arthritis. In young adults, the incidence of SLE, rheumatoid arthritis, and all these arthritis is definitely more as compared to children. In older adults, it would be more of degenerative osteoarthritis, polymyalgia rheumatica associated with some other form of inflammatory disease, crystal arthropathy like gout and pseudo-gout, and osteonecrosis. I think you must be aware of the word AVN, avascular necrosis. So osteonecrosis, avascular necrosis is almost the same, some technical glitches there. Okay, sex predilection, men are definitely at more risk of developing gout, spondyloarthropathies as well as hemochromatosis. Women at more risk of development of rheumatoid arthritis, fibromyalgia, SLE. Ahir madam is going to tell you what exactly are the genetic differences, that why women are at more risk of developing these diseases as compared to men. Familial aggregation as well as familial arthritis, you must be aware of familial OA. Okay, so familial aggregation do exist in few forms of arthritis. So this is the, I would say, edifice of monoarthritis, that whenever the patient is coming to you with the complaint of monoarthritis, what all things, monoarthritis has been divided into different parts, like pain in seconds, it would be usually traumatic, pain over several hours to days, it would be infection or crystal arthropathy, insidious onset, it would be indolent infection or a primitive stage of inflammatory arthritis which would be progressing to involve other joints, a bilateral symmetrical involvement. So from here it would be a case of polyarthritis. I am very sorry that I combined these two tables into one, but for your understanding, just try to focus upon the left part. Okay, don't mug up the things which are there given on the right. So for your understanding, the simplest definition of rheumatoid arthritis for you to understand, it is a chronic onset or a chronic arthritis involving bilateral limbs of your body, small joint more than large joint, upper limb more than lower limb. See, it is very simple. Intravenous drug abuse, if at all you are able to decipher this history, then septic arthritis should be your differential. And spontaneous resolution of the acute attack, crystal arthropathy, and also nowadays, especially after the post-COVID era, there is somewhat more incidence of palindromic rheumatism. Okay, this is an observation which has been done by most of the physicians as well as orthopedicians, that these patients having severe, especially severe COVID, that after the recovery, these people tend to get intermittent attacks of arthritis which usually resolve within say 72 hours, 48 to 72 hours, and there is the residual weakness is not there, the residual damage is actually not there. So this is actually what is about palindromic rheumatism. So even you need to remember that. So coagulopathy, use of anticoagulants, hemarthrosis, coagulopathy, especially if we are dealing with Christmas disease or factor 9 deficiency in pediatric age group, they will be present to you with hemarthrosis, because even a trivial trauma to large joint will give rise to joint inflammation. The recent prolonged course of corticosteroid therapy, again we need to keep in our mind that what all the steroid abuse had been done at the time of COVID. So that has resulted into infections, multiple infections, avascular necrosis, especially avascular necrosis of hip. However, even avascular necrosis at other parts have been documented. These all points I would, the systemic manifestation I would take in my another slides, because I need to explain it to you with diagrams. So these are the differentials for monoarthritis for acute as well as in chronic, the inflammatory as non-inflammatory origin, which in the inflammatory group it includes septic arthritis, gonococcal, acute forms of inflammatory which would be progressive to involve the larger joints and the other joints of your body. In the chronic arthritis, we need to understand tubercular, fungal and brucellosis. Definitely, just on the basis of clinical examination, it is not possible. Believe me, it's not possible to differentiate between tubercular arthritis, gonococcal or brucella, anything, whatever it is. So you need to have a histological diagnosis as well to prove it. Inflammatory, non-inflammatory one, traumatic, and most common is OA. So possible causes of acute polyarthritis, this is all theoretical. I will like to skip this slide. The possible causes of chronic polyarthritis, it's only the nomenclature, but you need to keep in your mind that what all it can be in the inflammatory group involving RA, psoriatic, ankylosing, polyarticular gout, in the connective tissue involving SLE, Behçet, PAN, in the non-inflammatory one, generalized OA, especially the familial OA. So a very important point about pattern and topography of joint involvement. So pattern of joint involvement means that how the disease is behaving over a period of time. Okay, so additive onset means that one, I will go the reverse way. First focus upon the migratory arthritis. So migratory arthritis, you must have read something about acute rheumatic fever. Okay, the fleeting arthritis. And what is that peculiar line which is said about acute rheumatic fever? That it licks the joint and bites the heart. So this form of fleeting arthritis, that once one joint is involved, the other joint would be getting involved and there would be resolution of inflammation in one joint and would be affection of the other joint. So this is what is called as migratory arthritis. So intermittent arthritis, just what I said about palindromic rheumatism and all. There would be acute attack and there would be resolution. It's something like an acute attack of bronchial asthma. Okay, once the attack is resolved, the patient is almost fine. Okay, this is something about intermittent arthritis. Additive arthritis, this is again the behavior of disease, that at one time it would be affection of one joint, then another involving the polyarticular course. Okay? I hope my lecture is not that boring. So these are the differentials about additive, intermittent and migratory arthritis. Again, very theoretical one. Coming to the topography of disease. Okay, so what do you understand by this word topography? In something related to geography? Anyone? What about topography? The topography of a terrain, okay? Kahan par mountains hai, kahan river hai, kahan lake hai, something like that. And they are going to stay at there. So this is something about arthritis as well, okay? So topographic involvement. Whenever we say axial disease, it has to involve the axial skeleton, okay? So the joints coming in the axial skeleton include the vertebral joints, okay? The facet joints of the vertebra, an isolated one, the sacroiliac joint, should I be coming there? The sacroiliac joints over here, आहे का? ते कर्सर बरोबर होत नाहीये. ते माउस घेतला ना की ते वेगळंच काहीतरी ओपन होतं. Okay, let's not waste our time. So the axial skeleton, I think everything is visible to them. So the sacroiliac joint and so over here, the sacroiliac joint and the vertebral joint involvement in axial spondyloarthritis. Cervical joint involvement, again, it can be a feature of AS, ankylosing spondylitis, and in prolonged cases, long-standing cases of rheumatoid arthritis, especially the C1, C2 involvement. The peripheral joints, the peripheral joint involving the small joints of hand, actually I have only marked a wrist over here. The asymmetrical, then coming to the symmetry of joint involvement, asymmetrical means unilateral affection. So unilateral affection, I have focused knee joint over here and the joints of foot. Okay. So whenever we are saying something about axial disease, it means there has to be affection of the axial skeleton and or affection of root joints. Okay. Root joint means we consider hip joint and shoulder joint as root joint, as they have been rooted to the axial skeleton. The movement of these joints is not possible if there is no movement of spine. There should be some or the other movement of spine, or vice versa as well. Okay, whenever there is movement of elbow or your hip joint, there is some amount of movement at the hip, at the respective joint and the spine, that you need to understand, and therefore it is called as root joints. The explanation is very daunting, but I will explain it to you on the basis of this photograph. So over here, anyone, so chalo, let's make it much more interactive. What is this? Anyone? No. Anyone? Okay, who said? So Surya would be getting the award. Okay, what is this? Which balanitis? Cercinate balanitis. So this is keratoderma blenoragicum and cercinate balanitis, which can be seen, which is associated with reactive arthritis. Ma'am, syphilis, especially the secondary syphilis, it won't be giving rise to so much of exfoliation. It would be the papular lesions which would be present, but so much exfoliation is usually not there. In fact, the picture is not very clear, but keratoderma blenoragicum actually involves more of lower limb as compared to upper limb. So I'm very sorry for the pic, even the pic is not that clear. This one, anyone? What is this? Yes, which psoriasis? Plaque psoriasis. Okay, plaque psoriasis. You are getting whitish plaques over the eroded skin. So this is plaque psoriasis. What is this? ये क्या है? Yes, purpura, palpable purpura or purpura, associated with IgA vasculitis per se, Henox-Nonlin purpura. Henox-Nonlin purpura is only purpura, but whenever we call as IgA vasculitis, it should be associated with IgA, and the spectrum of kidney involvement, polyarthritis, and skin involvement would be there. Forget about this, I will explain it to you in this diagram. Okay, so what is this? Anyone? What is this? It's not something very fancy. Oral ulcer, yes, aphthous ulcer, oral aphthous ulcer involving the hard palate. No, this is not episcleritis. This is actually conjunctivitis, and if we can see over here, there is hypopion. Okay, so it is sterile conjunctivitis with sterile hypopion, which is associated with Behçet. Okay, so actually this is like oral mucosal ulceration and ocular involvement, that of Behçet. Okay, Behçet syndrome. This is actually rash of dermatomyositis, ocular rash of dermatomyositis and coalsma. There is no malar rash over here. But even dermatomyositis patient would be having joint pain, periarticular involvement, and all these features, and we need to differentiate from these typical features of skin involvement on that. Should I skip this or should I just enumerate? It is only it is all given in books as well. So somewhat one slide before summary, that what all clues you can get on clinical examination. अभी तक तो हम लोग सारा examination and history तो combine किए हैं. This is what is exactly something about the clues. So polyarthritis, especially with the distal interphalangeal joint involvement, psoriatic more common, psoriatic, OA and sarcoid. First CMC joint involvement, osteoarthritis, especially familial osteoarthritis common as compared to others. Acute arthritis with ankle edema, sarcoidosis. Dactylitis, the entire digit is getting involved, the entire digit is getting swollen, whether it is in the upper limb or lower limb. Again, the clue should be there with psoriatic arthritis. See, psoriatic arthritis, whenever you are having plaque-like psoriasis and joint involvement, the diagnosis becomes very clear. But believe me, 15% of psoriatic arthritis over there, joint affection will come first, and then it would be the skin affection that would be coming. And if you are having some atypical presentation, you need to evaluate for the hidden areas as well. So hidden areas like behind your ear, in the umbilical region, in the buttock region, in the buttock fold, especially the lower part of breast and axilla in female. Okay, even in the perineal and the vaginal area. So these areas needs to be examined, but definitely with the permission of your patient. Enthesitis means the site of joint affect, there's a site of insertion of tendon at a joint attachment. Inflammation like Achilles tendinitis, more common with in athletes and runners, but definitely a part of spondyloarthropathy spectrum. Plantar fasciitis, again, mechanical causes are more than inflammatory causes. Mechanical causes include faulty footwear as well. So faulty footwear, diabetes mellitus, inflammatory one again would be spondyloarthropathy spectrum. Sternoclavicular joint involvement in the center, axial disease, spondyloarthropathy group. Costochondral junction, it would be an enthesitis, again a part of spondyloarthropathy group, and a whole of spondyloarthropathy group in different. If you can see it all over here, it is called as a dactylitis, the entire digital involvement which is there. This is the costochondritis. Again, this is the enthesitis which is there. Okay. And the foot involvement in the patients with sarcoidosis. Very important part. Investigations. Whether you really want to evaluate for synovial joint, if at all there is synovial joint inflammation, is it? It is not. Radiograph, yes or no. Okay, so let's go on one by one. First important thing, synovial fluid analysis. So I will give you one clinical scenario. Okay, so a 25 years old man coming to you with low back pain and bilateral knee joint swelling. You gave the treatment, the pain has subsided, but the joint swelling is persisting in bilateral knee joints. Will you like to do synovial joint analysis? Anyone? Okay, raise your hands who would be going ahead with synovial fluid analysis. At least yes, you would like to go ahead with synovial fluid analysis. Okay, so one. Only one? Anyone else? Okay, two. Even madam is interested in going for synovial fluid analysis. At least raise your hands. Okay, one. Only one. So rest of the people won't be going ahead with synovial fluid analysis. Is it? So both the answers are true in their own sense. Going ahead as well as non-going ahead. So what all explanation which I gave in my previous slide, that we have to understand something about the behavior of disease. If we are very sure about our diagnosis that this patient is a case of spondyloarthropathy, a patient with axial and peripheral joint involvement, you need not go ahead with synovial fluid analysis. Okay, but if the suspicion of crystal arthropathy is very high, then you have to go ahead with synovial fluid analysis. So at least I am leftist in my, or centrist in my explanation. So the second important thing about the TLC count. So what is the normal TLC count? 0 to 200. Okay, and less than 10% of would be polymorphic. In non-inflammatory group, it is 200 to 2000. These are also again arbitrary differentiation. There is no LOC. But one thing is very clear, that if the synovial fluid count is more than 50,000 with a negative staining for gram stain and more of polymorphic involvement, more of polymorpho leukocytes, the chances of having septic arthritis is very high. So just remember these three words: usually monoarticular, usually painful, associated with systemic features, synovial fluid analysis, more than 50,000, predominantly polymorphs. Chances of having septic arthritis is high. That is not diagnostic. If you are having something on gram stain which is there, you can very well take it as a case of septic arthritis. Okay? Urine analysis, especially if you are dealing with SLE or systemic vasculitis or pyuria or UTI, this can be a focus of infection that may spread to the joints causing septic arthritis, or it can be a harbinger of producing reactive arthritis. Acute phase reactants, ESR, CRP, reversal of AG ratio because of relative hypergamma-globulinemia. Platelet count, yes, platelet count is a very good marker for as an acute phase reactant for inflammation. Increase ALP levels. Serological etiologies, if at all you are suspecting HIV, HBsAg, our triple H workup. EBV, something about EBV, especially if the patient is coming to you with polyarthritis, with polyglandular involvement, with an indolent course, and presenting to you as cytopenias. This can be one of your differentials. Okay. So just think about it. Don't just ignore that this patient is having sepsis and we need to treat it with higher and higher amount of antibiotics, because that would be even more harmful to the patient. Autoantibody workup, rheumatoid factor, anti-CCP antibody and ANA. So हमारे reports में क्या गलत है? Which I have always pointed to my residents. We are writing it as RA factor, if you have ever noticed. So there is no entity called as RA factor in the world. It is existing only at GMC Nagpur. So it is not RA factor, it is called as rheumatoid factor. Rheumatoid factor positivity doesn't mean that you are having rheumatoid arthritis. Okay? Rheumatoid factor is nothing but an antibody which is directed against IgG. So anyone can have it. Even a trivial viral infection can give rise to rheumatoid factor positivity. That doesn't mean that the patient is suffering from rheumatoid arthritis. For rheumatoid arthritis, it's a clinical diagnosis. You have to be very pertinent about few points and then able to classify into one. Okay. So henceforth, do not ever write about rheumatoid arthritis factor. Say rheumatoid factor. Okay. So self-improvisation is necessary at our level as well. Anti-CCP antibody, much more specific as compared to rheumatoid factor. Anti-nuclear antibody, not very diagnostic of ANA, but definitely has a very important role in the diagnosis of SLE, but having a very important role in the diagnosis. What is the population of India? Anyone? I mean, this is not something very scientific or a medical question for which you need to read. Kitna hai? What is it? We are now number one in the world. We have surpassed China, so at least we should be proud of it for something, being an Indian. क्या है? How much is? अरे ये GK का question है यार. हाँ? नहीं 1.5 time है इतना जाने के लिए time है. It will take another at least 6-7 years for us to reach that time. कितना है? 1.41. कौन बोला 1.41? अजिंक्य? नहीं अजिंक्य नहीं बोला. कौन बोला? At least you shouldn't be ashamed of this. You have given a right answer. Oh, so Amit gave him. But I won't be able to award you something. So our Indian population is 1.41. And there is study by Dr. Anand Malaviya, an ex-HOD of medicine from AIIMS. So what his study and what his cohort actually says that 7% of North India, the grape zone is 6 to 8% of North India is having rheumatoid factor positivity. ठीक है? अगर इतने ज्यादा rheumatoid arthritis होंगे तो our OPDs would be full of only rheumatoid arthritis patient and nothing else. But for your knowledge, these patients, this 7% patients, to take an average of, only 0.01 patients would be having clinically differentiable arthritis, which is rheumatoid arthritis. Okay? So just keep in mind, just because rheumatoid factor is positive doesn't qualify a patient to be started on treatment for RA. Radiology. Okay, chalo. इसमें rheumatoid arthritis में what all MCQ things which you have read in the during your preparation time, just tell me what all things can be there. In the other one, that rheumatoid वाला, इसमें क्या है इसमें? क्या हो सकते हैं just after seeing this radiograph? Okay, Swan neck, then okay, subluxation, there is ulnar deviation, there is Z deformity. The most important thing which I wanted to highlight is erosion. So the most important thing I wanted to highlight is something about erosion. If we can see, if we can focus our attention at this part, there is complete destruction of the interarticular joint space. Okay, and there is something crenations which have taken place at the bony joint order. Okay, so these are called as erosions, which we are more concerned about treating is that irrespective of etiology, irrespective of what antibody is present, irrespective of duration, if at all the patient is showing erosion, if at all you are able to document even one erosion, that patient needs to be started on treatment. And over here, चलो ये क्या है बता दो, ये क्या है, what is this? Anyone? नहीं, arthritis mutilans नहीं है. This is telescoping. This is telescoping. Penicillin cup इसमें आता है. This can be penicillin cup. This is telescoping. Ultrasonography, again a very high profile modality, very important, especially if you want to diagnose whether the patient is having crystal arthropathy or not, especially in gout. What you over here actually I've highlighted a double contour sign, but very difficult for you people to understand. But just remember that if at all in PGC super specialty entrance exam you get a question about double contour sign, you are just see for gout in your answers. Okay. So my take-home message would be history and physical examination are the best tools for diagnosis. You don't require investigation for diagnosing every patient of arthritis. Most common causes of polyarthritis include OA and RA. You just keep in mind, especially if the patient coming to you at early ages, before 60, RA most common, after 60, OA most common, if at all the starting point, okay, the starting of arthritis has taken place after this 60 ka LOC. Extra-articular features, you are very good at observing, so definitely look for those features. Pattern recognition, as what I said, whether it is symmetrical, asymmetrical, axial versus non-axial involvement, any extra-articular involvement, what are the peri-articular involvement, keep in mind, see for it, okay. Course of disease progression, whether acute or chronic, and investigation should be advised very judiciously. Otherwise, you may classify at least 6% of India's population to be having rheumatoid arthritis. Okay, so this should not happen. So I am thankful to you all. And